All right, good evening, everybody. We're really excited to be welcoming you all to Global Surgery, What and Why. This is the first talk in our 8-part webinar series, and it's just really a privilege for us as the UCT Surgical Society with the UCT Division of Global Surgery, as we try and understand the core tenets and principles of this field of global surgery and what it means for us. So over the next few months, we're going to be dealing with controversies, we're going to be dealing with systems thinking, and just really everything in between. And the goal is that every person who comes to these talks will leave with an understanding, passion, and some skills needed to play valuable roles increasing access to surgical care in South Africa and Africa. So without further ado, we kept you waiting for long enough. I'd like to hand over to Prof Vegan to welcome and introduce the speakers. Just a reminder that if you have any questions at all throughout the presentations, you're welcome to send them via the chat function to Katie, who will then relay them to me, and the speakers will answer them at the end. Cool. Thank you, Prof Vegan.
Great. Well, thank you, Regan. So thank you so much for getting this going. I'm looking forward to the series of 8 very, very interesting webinars. So I've been asked to give a little bit of a background on why global surgery kind of got established as UCT and what we're trying to achieve in getting this very exciting partnership going across a bunch of different departments in our faculty. And I think before one really talks about global surgery, it's just important to remember that global surgery has to always be looked at in the context of global health. And global health is different from international health, which is really about people going and trying to help and creating partnerships. There's a very deep sense of equity and really making a difference and transcending kind of interdisciplinary boundaries in global health. And that really kind of is very much the spirit of global surgery. So when you look at the sort of history of surgery in global health, it's really been very recently that the role of surgery has really been recognized. And in fact, one of the World Health Organization Director Generals, Maher, who was responsible for the Alma Ata Declaration, famously referred to surgery as the neglected stepchild of global health, because it really kind of somehow seemed that surgery didn't really fit in, that global health kind of addressed communicable diseases, infections, and that sort of thing. Surgery just needed too much in the structure, and it was just kind of clumsy. It didn't really fit in anyway. But that really was kind of very naive, because there's so many treated surgically that have a huge impact on the burden of disease, and not just trauma and patients with tumors in low middle income countries. The vast majority of malignancies actually need surgery because we don't have expensive chemotherapy and biological treatments. Obviously, congenital abnormalities generally need surgical intervention, and there's a whole gamut of pregnancy-related conditions that need surgery. So it's really important in any healthcare system that you have adequate access to surgery. And I think that sort of neglect of surgery as a key part of global health changed very dramatically 5 or 6 years ago, when the Lancet Commission was published, Global Surgery 2030. And that really had some findings that really kind of galvanized interest in global surgery as a discipline. And probably the most remarkable was the contention that around the world, of the 7 billion people in the world, over 5 billion didn't actually have access to safe and timely surgery, which was really quite incredible. And there was a treatment gap, that I guess you could call it, of 143 million operations a year that needed to take place that just weren't happening in low middle countries. And because of that, I think the estimate was that around 16 million people a year were dying because they didn't get access to treatment, which is incredible. It's sort of 10 times the number of people who are dying from HIV. So it's astonishing that it took so long for kind of organized healthcare in the world to recognize this huge gap. But one of the things that really struck me when I read that paper 5 years ago was it was even though South African authors, It was an incredible group of distinguished academics from around the world, but there was no one on that paper from South Africa. And it really struck me that somehow South Africa had sort of dropped off the pace in this field. And it didn't really make sense, because there were enormous numbers of South African surgeons making really incredibly important contributions that really kind of, in my view anyway, kind of were highly relevant to global surgery. And when I looked around, it was really striking how many people were doing things that were important in terms of global surgery. So in neurosurgery, for example, which is my discipline, we're training a lot of neurosurgeons out from other African countries. And it's very clear that we were able to offer trainees something that they weren't going to get if they went to train in the global north. And there's real relevance to what we were doing. ENT had amazing training programs, young surgeons from around Africa. Oncology, which many would consider to be quite an incredible program of community eye health and training healthcare workers from low middle income countries how to prevent and treat blindness. Even the cardiac surgeons were in on the act. The Cape Town Declaration sort of really setting out to deliver treatment to patients with congenital and other infectious heart disease, and trying to take kind of sophisticated healthcare to low middle income countries. So there was a huge range of different things happening at GCT that kind of needed to be part of that worldwide global surgery kind of debate. And I guess I had an opportunity to change that when I became HOD a few years ago. And with the Department of Anesthetics, Department of Obs and Gynae, and also Public Health, we decided to really kind of set out and kind of create a bit of a coalition at GCT to develop global surgery. And it's really important. I mean, I'm really chuffed that there's somebody on this first webinar from Public Health, because in a way that was probably kind of revolutionary aspects of global surgery, that actually surgeons and anaesthetists and obstetricians would now be working with people from Public Health, which is so obvious that actually if we really want to leverage what we're doing and sort of make it applicable on a much wider basis, we have to work together in partnerships like this. We've had a few people at GCT that have really sort of led the charge with global surgery. I want to mention in particular Katelyn Pye, who's the general surgeon who was at GCT, who's now heading up global surgery at Stellenbosch University, who in a sense kind of really got the ball rolling. Our next breakthrough was recruiting Salome, and for I don't think there's a single person on this call who probably hasn't met Salome. Salome joined UCT just a year ago, and I'll tell you a little bit more about her in a moment. But I think what that's really done is catalyzed an amazing range of partnerships, not just internationally, and I think it'll be very apparent over the course of these 8 webinars that global surgery truly is a worldwide endeavor, but also partnerships with institutions. But probably most exciting of all is partnerships that have happened within our OCT. And I don't think any of those partnerships is more exciting and there's more potential than the link between global surgery and SURGSOC, the Student Surgical Society. One of the key aspects of global surgery is the opportunity for innovation and for thinking differently and thinking in new and exciting ways about old problems. And I think this synergy between global surgery and Surgical Student Society is a really, really rich. So just to kind of get on to the 2 speakers that we have tonight. So Salome Maswime is a graduate of UKZN who then did obstetrics and gynecology at Wits, qualified as a specialist, got an MMed and college specialist exam, and then stayed on at Wits to do a PhD. After a couple of years, Salome won a Discovery Award, which took her where she spent a year at Massachusetts General Hospital, and really at Harvard that she kind of discovered and fell in love with this field of global surgery. And just as we were kind of getting momentum at GCT to try and develop global surgery, we heard about Salome and come back to South Africa, and fortunately was keen to come to UCT. So thanks to the intervention and help of our Vice Chancellor, Professor Pakeng, we were able to secure some funding and get Salome to UCT. And I think it's been very clear to everybody. It's been an absolutely sensational development, I think, for us and Salome, hopefully for you too. Been tremendous opportunities to build alliances here and really get things going. Lots of accolades. And probably the greatest of those is Salome recognized as a World Economic Forum Young Scientist a few weeks ago, which is really incredible recognition of the work. But as I said, it's not only about surgery and obstetrics and anesthetics, it's also about public health. And Nisha Jacob is one of the most distinguished recent graduates of our public health program at UCT. Nisha is a UCT graduate who stayed on to specialize in public health at UCT. Graduated 5 years ago with the gold medal for the most outstanding candidate in the country with the public health exam. Completed a med, and for those of you who are undergraduate students, you'll know that Nisha also convenes the fourth year public health program, health and content, and is also involved in postgraduate training and mentorship in our department. So without any further ado, I'm going to hand over to Salome, who's going to tell you, I think, a little bit about the what of global surgery. And then I think Nisha is going to tell you a whole lot more about the why. So Salome, over to you.
Thank you so much, Graham, for that introduction. And I mean, it's been an absolute pleasure being part of UCT for the past year and creating this, and part of which I'm also going to present to you today, what we've done and what we do. But it's been so exciting to learn what global surgery is, for Cape Town and for UCT and for the African continent, and developing this into a new discipline. And so I'm going to start with my talk now, and really talking about the what and a bit about the why, as Graham has already said. And so I won't mention all of these statistics that have already been mentioned, but just want to highlight really that, you know, if you look at access to healthcare across the world, 1.3 billion people lack access. Now surgery, which is seen as more of a specialized healthcare, just looking at the gap, at least 4 billion more people don't have access to surgery. So it's really, as has already been highlighted, it's really something that needs a lot of attention. And what we've seen is a lot of this can be dealt with by looking at health systems, and just highlighting some amazing work that was done nationally, led by Professor Bruce Pickard in South Africa and in Africa. Look, this is the African Surgical Outcome Studies, which really are a landmark trial in terms of global surgery. And what was found initially was that the mortality from surgery is 2 times higher in Africa than in the rest of the world. But I think the alarming finding was with cesarean sections, and that it was women are 50 times more likely to die in Africa than in the rest of the world. And this is very important because you can link it, you can see the real link between access and outcomes. And so whilst you've got a huge gap in access, but you've also got this high number of people that die due to surgery complications. And when you start unpacking why, you start seeing the quality of care issues coming up. So I've used the global surgery definition. The international definition that global surgery is an area of study, research, practice, and advocacy that seeks to improve health outcomes and achieve health equity for all people who need surgical, obstetric, and anesthesia care, with a special emphasis on undeserved populations and populations in crisis. But what we have really done as UCT is to look at what global surgery means to us. And, you know, we've spent the year kind of unpacking that. And so our summary is that it's really a transdisciplinary approach to providing equitable, comprehensive surgical care. Our vision is a world in which all people have access to quality, comprehensive surgical care, and our mission is to improve equity and access to quality surgical care in Africa through education, research, advocacy, and implementation. So when you look at surgical care from a clinician's perspective, we tend to divide it up according to the different specialities, because we know that what obstetric surgery needs and entails is a bit different from what oncology entails. And so these are kind of the 5 priority areas when you're looking at the global burden of disease. But if you zoom into, health systems, it's a very different outlook. And I won't go too much into this because this is probably some of the work that Nisha will cover. But I thought I should mention it and bring it more from a surgeon's perspective. I still call myself a surgeon because, I've spent a lot of my life doing obstetric surgery. And so, much as the previous slide shows you how we tend to look at things, that how you look at it from a health system perspective is very different. And so whilst many of us will understand issues around service delivery, which I've highlighted in red, which is what we really do as clinicians, what happens in the first column really determines and the services that we can deliver. So the issues around health workforce, financing, information, governance, medicines, vaccines, infrastructure, all of these things are really going to determine what access our patients have to healthcare and the quality of care that they receive. And so an important part of healthcare is the investment in all of these things. And so, especially in Africa, where we've looked at what is the real investment in surgical care, when you look at the actual leadership on how resources are governed and how the finances are used and how all of that interprets into service delivery. But I also just want to mention that whilst we're not looking only at what the surgeon does in service delivery, we also feel that looking at promotion, rehabilitation, and prevention are a very key part of global surgery. Because, for example, issues, for example, say gun violence, when you look at trauma and look at injuries and, if you don't look at the prevention issues, you won't reduce the number of cases that we have. So it's not just about improving access, but how do you reduce the actual surgical events so that you can have better outcomes. So I've highlighted also just in the third column, morbidity, mortality, but also just wanted to highlight that, it's not just counting the immediate effects, but how many people had loss of function and were not able to return to work because of disability, because of, loss of income. So there's a lot that happens that determines the outcomes when we don't have good care and when there isn't a good investment or leadership in service delivery. So a comprehensive global surgery approach, we see it as education, research, implementation and innovation, advocacy and diplomacy. A lot of the work, I think, initially that has gone into defining global surgery or key areas in global surgery has been policy and a lot of work around the NSOPs. You've seen some of the research that's going on and how that has really helped to define global surgery and the importance of global surgery. But now that, we're starting to accept that, it's not only teaching global surgery as a discipline and some of these things that I'm talking about, but also the education that goes into surgical training, the rehabilitation. There's a lot that needs to go into strengthening healthcare and strengthening the health system. So as UCT, I think our 2 key areas are on education and implementation and surgical innovation as well. And those are kind of the things that we've been developing and strengthening, because we believe health systems strengthening is a very key component of improving health systems. And so the concept of social medicine, social medicine prioritizes health equity, promotes a broad view of health, promotes multi-sectoral action, and promotes participation of communities. And so this is when we look at how social factors determine healthcare, or if you want to call it the social determinants of healthcare. And so it's important that when you look outside of what's happening in the hospital or outside of the theater or the surgical wards, that, if some patients will do well in hospital, but afterwards will not do well because of the poverty that they live in, because of the circumstances that they live in. And if we don't factor that in as a surgeon, you keep having bad or not so good outcomes, perioperative outcomes. So it's important that we understand social medicine and look into that as well. So health equity is the absence of avoidable, unfair, or remedial differences amongst groups of people, whether they're defined socially, economically, demographically, or geographically, or by any other stratification. Everyone should have a fair opportunity to attain their full health potential, and no one should be disadvantaged from achieving this potential. Human rights is also an important part of global surgery, just understanding and seeing health as a human right and the legal obligations that we have as a country to ensure that there is access to timely, acceptable, affordable health care of appropriate quality, to provide for the underlying determinants of health, so the responsibility that the country has, not just to provide health care and surgical services, but that there is water, sanitation, food, housing, health-related information and education, gender equality, because ultimately these are the things that will determine how patients do before and after surgery. And then the concept of social justice, and seeing social justice, it's a just distribution of goods within society and examines the relationship between groups and individuals that influence the distribution of goods, advocating for the poor and for solutions to the structural barriers that deny them access to affordable, adequate healthcare. And I thought this was a really important quote, because whilst we want to look at our clinical duties and our clinical work and our surgical work, there are structural barriers that we need to understand as clinicians as well. And when we understand that, then we, as surgeons, we can also become agents of change. So what is global surgery? A lot of surgical work has been focused on the surgeons and the surgical disciplines. And this is kind of how the conversation evolved, that from surgery, bringing in the obstetricians and gynecologists, bringing in the anesthetists. But, you couldn't have a global surgery discussion without bringing in public health. You can't talk about global surgery without talking about the politicians, the decision makers. You also need the scientists to start understanding surgical diseases as well. You need the economists to help us with health economics and understanding how financing and all of that contribute. And you also need the social anthropologists to understand the social side of medicine. So, I quickly, just before I summarize, I also just want to elaborate, just touch on what we've done with COVID-19. And as global surgery, it's been a real time to use some of our principles, because as you'll see, global surgery applies to everything. The principles that we use for global surgery can be used across healthcare. And so we've had a number of programs that we've run over the past few months, ranging from creating applications, telemedicine, creating biomedical devices in partnership with the biomedical engineering department, to creating national guidelines, running national, international studies as well, and also working on it in COVID-19, regards to COVID-19. So in summary, there is a great need for healthcare globally and a much greater need for access to surgery. Global surgery, I would really say, is a transdisciplinary approach to equitable, comprehensive healthcare. Health equity and social justice underpin global surgery principles, And in conclusion, global surgery is really a transdisciplinary, multi-sectoral approach to providing equitable, comprehensive perioperative care. Thank you very much.
Thank you so much, Prof Maswime. Really appreciate that. Just a quick note to everybody that we can't seem to get the chat function working. So if you have any questions for the speakers, please email me. I'm the email address that sent you the link for the Zoom invite. So if you email me directly, even if you just reply to the original email with your question, I will then pass those on to the speakers later. We can just have Dr. Jacob have her presentation now.
Thanks very much, Regan. So can you all hear me and see the screen?
Yes, we can. Thank you.
Perfect. So good evening, everyone, and thank you very much for the invitation to speak today and the very kind introduction by Prof. Vegan. So the Surgical Society was born when I was an undergrad at UCT. The society has flourished and developed over the years. So in today's talk, I thought I'd start off with some uncomfortable realities to set the theme, and then talk about the role of public health broadly and within global surgery, and finish off with some considerations for undergraduate training. So every time I'm in a surgical engagement, I keep asking myself, what on earth am I doing here? So as a public health physician, I've had a rather limited connection to surgery. And after my undergrad and internship, perhaps the last time I was properly in theater, I was a patient having an emergency cesarean section. And currently my closest link to surgery is probably my husband over there, who's a cardiothoracic surgeon. But my experiences in public health and being married to a surgeon makes me acutely aware of the siloed nature of medicine. So it is well known that medicine is hierarchical in nature. Interdisciplinarity is well described in the literature, but is often not implemented in practice. So when I was a burnt out intern, I naively thought that the solution to improving the situation in our health facilities was more staff and more resources. And an inherent desire to fix the system is what led me to public health. But it was only in my registrarship that I came to realize that we needed a systems approach that would address the root cause. We needed to step back and disrupt the silos that stop us from achieving greater efficiency and quality and simply throwing more resources. And so within medicine itself, this siloed nature is further perpetuated between different specialties. Most medical students will be familiar with humorous algorithms like this. But of course, my specialty of public health medicine does not feature at all here. And while this is a joke, it leans towards the mentality that each specialty is made up of certain types of people to be left alone to do what they do best. And so in this figure, Australian medical students have ranked medical specialties according to prestige and lifestyle. And you can see how surgery, anesthesia, and obs and gynae rank very highly in terms of prestige. So very surprisingly, public health medicine has made the cut and features on this figure right at the bottom with the very least prestige. And in any social setting, my husband will get all the oohs and ahs because he saves lives, while I'll get the classic, what is public health? Is it admin? So why am I telling you all of this at a global surgery talk? So this siloed nature has an impact on how we address health problems and how we train upcoming healthcare professionals. So those of us in public health are quite used to the professional and societal attitudes towards our specialty. And we recognize that the specialty is so broad and diverse that the scope is often incomprehensible. But I became involved in global surgery as I saw for the first time a concerted effort to disrupt silos within medicine, as well as between disciplines and professions that all play an integral role in the health system. So Salome has given an excellent overview of what global surgery is and why it is needed. And Prof. Vegan has specifically referenced the Lancet Commission on Global Surgery, so I won't elaborate on that. But what I would like to do is take us to that famous quote by Paul Farmer, who said that global surgery is the forgotten stepchild of global health. So while I acknowledge the sentiment, it does beg the question as to what is global health. And I think Prof. Vegan alluded to some of the controversial terminology around here. So in the public health community, this concept of global health is one of much debate and disagreement. There are many definitions offered in the literature. So Katelyn et al. Define it as the area of study, research, and practice that places a priority on improving health and achieving equity for people in health for all people worldwide. But for many, there is no difference between global health and public health. And you may know that there are concerns that global health is a form of neocolonialism developed by the global north in a misguided attempt to save the global south. And contributions to the actual definition of global health have largely come from high-income countries. So while this may be a harsh criticism, many public health colleagues in the country feel that our focus in South Africa should be on strengthening our own health system and addressing health equity using the expertise of our own who live and understand our context and share these lessons with others rather than entertaining global health agendas. But a question that often comes up is that if global surgery is part of global health, then is it not open to the same criticisms and resistance? So there's extensive literature looking at these issues, and I won't delve into it. But I do feel that one must have an understanding of this background and the different perspectives when approaching global surgery, as this is one of the aspects that may cause resistance. And we need to embrace this, and we need to know how to work with this. So personally, I'm not convinced that global health is any different to public health. So let me move on to public health specifically, and let's interrogate whether public health fits in with global surgery. So public health was originally defined as the science and art of preventing disease, prolonging life, and improving quality of life through organized efforts and informed choices. So the key points to highlight are the focus on prevention, that public health looks at the population at large and not just the individual, and that it is broad and not limited to a specific disease, clinical discipline, or area, be it a district like Southern Western, a province, a country, or many different countries. And it recognizes health as a basic human right, as Salome has pointed out. So the principles of public health are equity, social justice, participation, efficiency, effectiveness, acceptability, affordability, and accessibility. And so from these principles, it's quite clear that there is overlap with the definition and purpose of global surgery, the philosophy of primary healthcare, and the principles of universal health coverage. But from the definition of public health, however, it's clear that the main focus of public health is on prevention. But this concept is often misunderstood, even by experienced clinicians. And so this slide I've shown to the MBCHB students in second year, fourth year, and recently in sixth year too. And the reason I keep showing it is that it is fundamental that an integrated healthcare practitioner recognizes their role at all levels of prevention. So as you know, different levels of prevention target different groups, from the overall population in primordial prevention to tertiary prevention targeting those with an established health problem. So from a public health perspective, much of the focus of clinicians is on tertiary prevention and to a lesser extent, secondary and primary prevention. And looking at surgery specifically, sometimes a recognizable conflict is that the advocacy role of global surgery sometimes is thought to be to increase resources for surgical services, whereas public health would look to decrease demand for surgical services. But in order to truly address any health issue, primordial prevention is key. And the focus is then on improving health and well-being of the population in general and facilitating access to a range of health services when needed. So the COVID-19 pandemic has clearly illustrated that if primordial prevention strategies are weak, everything else crumbles. So without adequate housing, clean water, healthy diets, access to healthcare, safe roads, alcohol legislation, efficient health systems, and health promotive policies, any health problem becomes exponentially worse, and we face a losing battle by only focusing on tertiary prevention. And while the link between, for example, safe roads and gun violence and surgery may be somewhat obvious, a healthy diet, for example, may seem far removed from surgery. But obesity, for example, has a direct link to poorer perioperative outcomes, is a risk factor for multiple illnesses, and now we see is also a poor prognostic factor for COVID too. So this picture representing the upstream and downstream determinants of health is another one that my students have seen countless times. And again, it represents the need to strengthen services downstream using a systems approach, but importantly, curtail the problem upstream as well. Unfortunately, however, many healthcare practitioners feel that their role is only downstream, and they fail to recognize the power that they have to influence meaningful change upstream. And for me, global surgery recognizes this, as evidenced by the interdisciplinary nature of this emerging field. So how can public health contribute to global surgery? Firstly, by recognizing the need to address surgical issues and advocate for prevention of these issues at all levels, to look at the bigger picture beyond the individual when approaching problems, and this alludes to the WHO health system building blocks that Salome referred to, promoting interdisciplinarity and drawing on lessons learned from other disciplines and fields, generating evidence through research to monitor, evaluate, and strengthen the health system, and implement strategies to improve access to healthcare and health equity. And lastly, and very importantly, training future healthcare professionals in integrated approaches to health. And this brings me on to undergraduate teaching. So our students are well aware of the heavy and loaded undergrad curriculum. And as with public health in general, there are many competing priorities. And an added challenge is the method of training future healthcare practitioners, which is even more challenging under the current crisis that we face. So educationalists will tell you that evidence strongly supports an integrated approach to learning. And the new curriculum for MBCHB, which I'm most familiar with, embraced this integrated approach, but was not without challenges. So I happen to be in the second guinea pig class of this new curriculum. So problem-based learning of PBL, becoming a professional, becoming a health professional, and integration of disciplines were all part of my own training. And I'll admit that this was challenging. When we reached our formal clinical years, however, this integration was effectively disbanded and we were back to silos, which was much easier to follow. When I became a course convener, however, I was again made acutely aware of the importance of integrated learning, as well as the accompanying challenges in delivering integrated learning. So from a public health perspective, we have a limited time with students in which we are only able to superficially expose them to the breadth of public health. And previously, we had the opportunity to expose students to the conduct of research, but due to time constraints, we no longer have this opportunity, and it's only taken up by students with interest and perseverance. We maintain, however, that our discipline should not be taught in isolation and is a lens that applies to all clinical disciplines. However, training students to apply this lens in every clinical discipline is logistically challenging and difficult to assess. And we know well that students primarily value what is assessed. Similarly, as teachers, we tend to focus on our areas of expertise, and therefore we feel the most comfortable in our own silos, making integration all the more challenging. So that brings us to the elusive question that my classmates and I have been asking from year one of MBCHB, and that is, what is core? So let's look at surgery, for example. So some surgical colleagues will tell you that the core aspect of surgery that a student needs is to be able to carry out good perioperative care, which is completely correct. So surgical techniques, systems thinking, improving access to surgical care would be deemed for interest, but not essential. And some may argue that these concepts will cloud out the core competency of good perioperative care. From a public health perspective, however, an understanding and application of systems thinking and an understanding of the patient's context are integral components of training of an integrated healthcare practitioner. And the question is, how do we find the right balance that adequately prepares our students for the realities that face them as young healthcare workers? So currently, we are living through one of the largest pandemics of our century. And this dashboard is now commonplace with both healthcare workers and the public. And we're all avidly following the progression of our curve. So if anything this pandemic has taught us, it's the importance of having systems in place before a crisis hits us. From protection of the vulnerable in our society, to having systems for monitoring and evaluation, to preparing our frontline workers to function in the face of disaster. So on this point, it's interesting to note that this dashboard did not emerge purely in response to this pandemic. The information system was already in place for broader public health use. However, the pandemic needs facilitated the use of an existing system to provide specific essential information about the pandemic. And simply put, this is what public health hopes to achieve, having sound systems in place that can adapt to any health need. So COVID-19 has also presented us with the unique opportunity to reimagine the way we teach undergraduates and to highlight the needs for integrated teaching. So the final year MBCHB students have recently gone through a rapidly developed course called Navigating COVID-19, which will soon be rolled out to the final year health and rehab students as well. So this course has its weaknesses, primarily as it was developed literally within 3 days. However, it allowed both staff and students to have a glimpse of what integration can look like in a clinical setting. So we've seen how this pandemic has touched every aspect of healthcare services and the very fabric of our society. And an integrated healthcare practitioner needs a broad understanding of all these aspects in order to truly uplift the population that they serve. So what can you do as undergraduates? Firstly, get involved in research and collaborate. Read, and understand the literature, including learnings from settings different to our own. Apply the principles of public health in whatever clinical setting you find yourself in, from surgery to psychiatry, etc. Consider electives that expose you to the bigger picture, both locally and internationally, and adopt a systems approach to whatever challenge you face. As a department, we're here to support interested students, and we look forward to collaborating with the rest of the global surgery team to support students in integrating their learning across disciplines and not limiting themselves to one specialty or one population. But embrace teamwork. Those who've been through my course will know all about its challenges, but embrace it as challenging as it is. So I'll leave you with Winnie the Pooh and Piglet, and I thank you for your time, and I'd be very happy to take questions and be guided by your responses.
Thank you so much, Dr. Jacob. What a great way to really open our scope of thinking about health and even about diseases that can be treated surgically. It's really a privilege to hear you go through some of that thinking and some of those concepts with us. I do have some questions that have come through. The first one is quite a big one, and this is, where does global surgery fit into already existing fields of health system strengthening, implementation science, WHO building blocks, etc.? How does it ensure it's not acting in silo and learns from these fields to build capacity? Prof Maswime or Dr. Jacob can answer, whoever feels comfortable.
I think I must say that that's exactly what we're trying to do. And by breaking the silos, by working together, by all the partnerships that we're creating, that's exactly what we're trying to do, so that it's not just one group of people that are coming up with ideas and trying to implement them, but we're working with experts, with people from different fields, and really engaging with people from different disciplines, fields, departments, organizations, institutions. And that's why I highlighted the transdisciplinary multi-sectoral aspect. So from Department of Health to World Bank to WHO, though we are engaging with people actively, so that we're not doing our own thing in a corner and rebuilding our own silo. It's all about changing that.
And how do you think the response has been from those different silos as you try and merge the skills and knowledges that are in between each of those silos? What are the responses from them?
So I think when I came to UCT, maybe I came at the right time, because it's been amazing just working with so many amazing, talented people who were already doing amazing work. It hasn't been, I haven't had the challenge of trying to convince people what global surgery is, but rather, let's work together. Let's so it's I've just been amazed at the different things that people are already doing and we're already doing, and using this as a platform to bring it all together and find solutions together. Of course, the questions in the beginning, whilst a lot of people have been doing global surgery work, they were not necessarily calling it global surgery. And so I think a lot of the work in the beginning was changing the misconceptions and trying to show people what this is and what it is not. And so I think when you do that, you get a lot more people on board. We have a huge team, whilst, you know, we've got very few people that are doing full-time. Well, I'm the one who's doing full-time, but we've got people, staff members who are 4 staff members who are part-time global surgery. And, you know, but we've got a virtual global surgery community of probably 30 to 40 people who are actively doing global surgery projects and doing work just within UCT. So that's been amazing.
Maybe I can just add there as well, Regan. So I agree with Salome that the team has really strengthened over the recent months and years. But to be honest, over the years, this concept has been, especially amongst many people I've spoken to, has been met with some skepticism as well, which is why I alluded to some of those conflicts and those uncomfortable reactions, because these are the challenges that one will face when, especially with an emerging field like global surgery. And it really requires a mindset to break the silos and remove those prejudices and try to work collaboratively. And that will, it will take time. And one needs to recognize these prejudices and be able to and actually manage them, acknowledge them, and work with them, and in order to demonstrate exactly what global surgery can achieve.
Well, thank you both. Next question is a bit more practical. What can be done or encouraged in order to reduce the cost of surgery, especially in low-income settings?
I'll hand that over to Nisha.
Okay, so in low-income settings, well, I think I spoke quite a bit in terms of how we can decrease the demand for surgery. So that, I think, is critical. And that is key to essentially my entire talk, that one needs to focus not just on the tertiary aspects of prevention. So a lot can be done just by actually reducing the demand and ensuring that those who actually need those surgical services get the services. But then there's many other strategies that are being used. For example, task shifting is one of the major strategies used in different countries to allow, to upskill various different cadres of staff to be able to conduct surgery. And there's multiple strategies like that are available. And perhaps also, I don't know if Salome wants to add in terms of the obstetrics and gynecology context, as a surgeon, what other strategies are available to limit resources, to allow the use of scarce resources in a surgical setting.
Yeah, so I mean, a lot of, and so the concept of learning from other fields and what others have done is also something that's important in global surgery. And just like the task shifting that Nisha has mentioned, the task sharing, using other cadres, teaching other cadres to learn how to do things, coming up with sustainable ways of doing things. A lot of global surgery work has been based around missions, for example, going to countries and setting up, and in a time like this during COVID, all those missions have to stop because borders are closed, for example. And so you need sustainable ways of doing things, not spending money on having a few doctors in one place for a short period of time, but actually investing in the training of doctors and specialists, so that they can carry on these programs. So there's a lot that can be done.
Actually leads perfectly into, there seems to be quite a bit of a way of thinking that if you want involved in global surgery, you have to move around the world, you have to go to different parts of Africa, you have to go to Harvard to study this. Can you be involved in global surgery by just staying in South Africa?
And I'll go first with that. One of the key things coming to UCT was really first understanding that global surgery is local surgery. You start at home using these principles to improve the system here, creating key partnerships here and working with people around in our communities. We've been doing a lot of work across different universities. We currently have got students in different South African universities, from Sefako Makgatho University, Limpopo, University. We're working with people that are here, and we're not expecting them to pack up and come to UCT. We're saying, do your degree there, we'll support you from here and find ways. So it's not about packing up. I think we're also trying to move away from the notion we are trying to save the world. No, we're not. We want to partner with other people, with other institutions, and working together to fixing or to improving outcomes here and there. It's multilateral partnerships. But of course, there are a lot of opportunities to do international collaborations and international work. And for those who want to use the global surgery experience to widen their international experience and knowledge, there are opportunities as well, as electives. So it's all individualized.
Yeah, maybe I can just add there, Regan, because this just reminded me of a comment made by, I think a student once who said that the undergraduate medical training doesn't train students to be able to go across the world and, represent elsewhere, et cetera. But I think our training is not geared for that. So our training is geared to be an integrated healthcare practitioner in the South African setting, but that doesn't stop someone from strengthening the system and sharing lessons and collaborating with the rest of the world and learning and reading from literature from around the world and applying it to different contexts. So I think that's key as students, for students to have an understanding of that approach.
Well, thank you guys both so much. One last question, and it's topical at the moment. How detrimental has the current COVID-19 pandemic been on global surgery initiatives and the overall surgical capacity in South Africa?
So I can honestly say that it hasn't been detrimental at all from the perspective of, I think COVID has also, and which was part of the slide that I tried to show, that one, there are a lot of principles from global surgery that we were able to apply. So for example, we're already working with telemedicine, with IT companies, and what we did was, let's put a pause on some of the initiatives that we've been working on, and let's see what we can do to respond to COVID-19. Being able to participate in global, guidelines on surgery, on pregnancy, being able to do all of that, writing publications to voice for surgical care in COVID-19, those are opportunities that have also come through this time. So I wouldn't say that, the pandemic has been a global surgery crisis at all, but, I think there are a lot of things that we've been able to use, just applying our principles as solutions for the pandemic.
So I think maybe just to add, though, the pandemic itself, as we know, is having multiple effects on various other healthcare services, and this has been demonstrated in different epidemics as well. So beyond surgery, so we know that there will be a backlog in surgery because due to the various closures, we know that people are not accessing healthcare as they used to, and we know there's a fear to access healthcare now. And so this has wide-ranging issues. For example, children are not accessing vaccinations, so we may have outbreaks of other infectious diseases soon. We've seen a significant drop in antiretroviral commencement of treatment. We've seen a significant drop in TB screening that's been happening during the pandemic. So the multiple effects of this pandemic will be felt soon, and surgery will feel that impact as well. And there will need to be a concerted effort, once we pass the peak and we sail through this pandemic, there will be quite a lot of work that needs to be done to support the health system and the backlog and issues created by the pandemic. And so we actually need to think about strategies as to how to handle that.
And maybe just to say, completely, the impact of COVID on surgery, that is a very, different question. And without going into that, there's a lot that we can say about that. But I think a lot of us at UCT have been part of that discussion, on the debates, and contributing not just to this question on a provincial, national, international, platforms. There's a lot that's being done to also try address the actual issues by the global surgery team and by all the departments involved in global surgery.
Cool, thank you so much to you both. I don't think we have time. There have been a few questions that have trickled in, and some of them are very interesting. Might have to address them in later parts of the series. I'm just going to hand over to Savannah to close us off.
Thank you. On behalf of the UCT Surgical Society, I'd just like to thank you all for joining us this evening for the launch of our new Global Surgery webinar series. And a special thank you to Prof Fegan and Prof Maswime and Dr Jacobs for the insightful deep dives into the what and why of global surgery this evening. This is definitely not a discipline that we get a lot of exposure to at university, and so I'm certain that the students have gained a lot from the insights that have been shared this evening. And I know personally it's made me very excited about the future of surgery in South Africa. And on that note, please keep an eye out for our next talk in this webinar series, where Prof Bruce Bickard and Dr Tracy Adams will be talking to us about the burden of surgical disease in South Africa. And this will be taking place in the week of the 6th of July. The date is still to be confirmed, so please keep checking our Instagram page for updates. And we look forward to seeing you there. Otherwise, enjoy the rest of your evening, and thank you so much for joining us this evening.
Thank you very much for organizing a fantastic webinar. It's great to see the passion and interest from students.
Cool, thank you guys. Thank you so much.